You probably assume that when you enter a healthcare setting, you're on the path to healing. It's an expectation.
Absolutely. That's the fundamental premise.
But what if I told you that for more than 1 in 10 patients, the exact opposite happens?
Hmm.
That instead of getting better, they actually experience harm? It's a stark reality we rarely confront.
It really is.
So today we're going to take a deep dive into this critical, often hidden issue, the profound burden of harm in healthcare. We've got a stack of research, real-world data in front of us that lays bare not just the immense human toll, but also the truly staggering economic impact of unsafe care, around the globe.
It's definitely a complex landscape we're about to navigate. What truly stands out in the material, I think, is just how multifaceted this problem is.
Right.
We'll be drawing insights from data spanning different countries, diverse patient groups, and a variety of medical settings, all to build a comprehensive picture of preventable harm and, crucially, why it profoundly affects all of us.
Okay, so let's confront those numbers head on. Our sources underscore that unsafe care isn't just a minor blip. It's a monumental global public health crisis. We're talking about more than 1 in 10 patients across various medical settings experiencing harm.
1 in 10. That's significant.
And here's a figure that truly demands our attention. Roughly half of that harm is completely preventable.
Half.
Yet it contributes to over 3 million deaths worldwide every single year. Just imagine that 3 million lives potentially saved if existing safety measures were, universally applied.
It's a staggering number. And when you zoom out and look at the global map, a really striking disparity emerges.
How so?
Well, approximately 2/3 of all patient harm and the subsequent years lost to disability and premature death are concentrated in low and middle income countries. LMICs, as they're called.
2/3 in LMICs. Wow.
Yeah, the data suggests an astounding 134 million adverse events in LMIC hospitals annually, leading to an estimated 2.6 million deaths. This isn't just a statistic. It profoundly highlights the vast global inequality in patient safety, where access to safe care is, well, far from universal.
That geographic disparity is really sobering. It makes me wonder, though, within these contexts, who are the individuals most acutely vulnerable to harm? Do our sources shed light on specific groups that kind of disproportionately bear this burden?
They absolutely do. The research points to several demographic patterns.
Yeah.
Older adults, for instance, are particularly vulnerable.
Okay.
Some studies show up to 16% experiencing adverse drug reactions.
16%.
And it's not confined to adults. Children, especially those with complex medical needs or reliance on medical technology, also face a significant and varied incidence of adverse events. What's often less discussed, though, is the nuanced impact across other groups.
Give us an example. What kind of nuances are we talking about here?
Well, consider gender. Our sources reveal that women are actually slightly more affected by adverse effects of medical treatments than men.
Really?
Yeah, with over 1.3 million people harmed in 2019, and women accounting for a higher proportion of fatalities and healthy life years lost.
Hmm.
Then there's the critical issue of health inequities for ethnic minorities. For example, Black adult patients in the U.S. have been shown to have significantly worse patient safety outcomes compared to white patients in the same hospital.
In the same hospital.
Exactly. And factors like language proficiency, differing beliefs about illness, maybe even the nature of interactions with health professionals can play a role.
That's complex.
It is. And beyond these demographics, patient complexity itself is a huge predictor. So someone with multiple chronic conditions like, say, hypertension, diabetes, or even obesity faces a significantly elevated risk of harm simply due to the sheer number of medical interventions and, the potential for interactions.
Okay, so we know the global scope and who's most at risk. Now, let's dig into where this harm is most likely to occur. When you think about high-risk environments, places like an intensive care unit might immediately come to mind.
Right, that's a common thought.
Do our sources confirm these intuitions about particular settings?
They do, quite clearly. Highly specialized settings are indeed high-risk zones. Intensive care units, emergency departments, and surgical units consistently show the highest rates of patient harm.
Makes sense.
Think about it. Up to 1 in 5 ICU nations experience harm.
1 in 5.
And these incidents can extend an ICU stay by nearly a week on average, pushing up overall hospital stays by almost 9 days.
Wow.
And surgical complications are truly staggering, affecting up to 25% of patients. Estimates suggest as many as 7 million surgical patients globally suffer significant harm annually, with a million dying during or immediately after surgery.
1 million deaths.
And crucially, about half of that surgical harm is considered preventable.
Half again. That's a huge number for specialized care. But what about more common settings like, a general hospital ward or even just your regular doctor's office? Are those as safe as we might assume?
That's a very good question, and the data might surprise you a bit.
Okay.
While specialized care definitely has higher rates of harm per patient, general hospitals still see approximately 10% of patient interactions result in harm.
Still 1 in 10.
Right. But perhaps even more unexpectedly, primary care, where most of us have our foundational interactions with the health system, has an estimated 7% of patients experiencing harm, though some global figures push that estimate as high as 40%.
40% in primary care.
Potentially, yes. An estimate suggests up to 85% of that harm in primary care could be preventable.
85%.
Yeah. The majority of these incidents, including diagnostic errors, which shockingly account for over 60% of primary care harm.
60% just from diagnostic errors.
In primary care, yes, along with medication-related issues and delayed referrals. And they're largely preventable. This really puts a spotlight on the need to strengthen safety right at the earliest point of care. Problems in communication, administrative processes, they often underpin these incidents.
It's clear this isn't just an ICU or operating room problem then. Our deep dive also surfaces other settings where harm is a persistent issue. I was surprised to see how prevalent it is in areas like mental health.
Mm,
Preventable harm for psychiatric patients is nearly double that of other patients.
that's right.
Or palliative care, where risks like pressure ulcers and medication errors can tragically disrupt end-of-life comfort.
Absolutely crucial settings where safety is paramount.
And even highly technical fields like radiotherapy aren't immune, with around 1,500 errors per million treatment courses often happening in the planning stage, raising concerns about, dose calculation.
Precision is key there, and errors can have serious consequences.
And who would have thought about dentistry? Our sources show a 1.8% prevalence of patient harm there, with issues like wrong tooth extractions accounting for nearly half of those cases.
It seems minor, but it's still significant harm for the patient involved.
Definitely.
And let's not forget newer frontiers, like telemedicine. Its convenience became, well, indispensable during the pandemic, right?
Sure.
But it introduces novel safety concerns. Diagnostic errors can arise from the absence of physical exams or maybe incomplete history taking over a video call.
Yeah, I can see that.
The data here is still evolving. It can be inconsistent, but it certainly underscores a critical need for more research and rigorous evaluation of its safety and overall effectiveness as a mode of care.
Okay, so whether it's a cutting-edge surgical theater or a routine dental visit, harm can occur. But what are the types of incidents that consistently pop up? What are the primary sources of this patient harm?
Right, breaking it down by source. Medication errors consistently stand out as the single most significant contributor. Globally, at least 1 in 20 patients experience preventable medication harm.
1 in 20, just for meds.
Yeah, and more than half of these incidents occur at the prescribing stage. That figure jumps to almost 80% in LMICs.
80% of prescribing.
And this isn't just about mixing up pills. It covers things like omitted doses, incorrect dosages, delayed medications. Common culprits are antibiotics, antipsychotics, cardiovascular drugs.
So really common medications.
Exactly. Following closely behind are diagnostic errors. They account for about 16% of preventable harm globally, often rooted in issues with, taking a proper history, doing a thorough physical examination, or misinterpreting test results.
16%. Okay, so meds and diagnosis are the big two. Beyond those major categories, what else makes the list?
Well, other major sources include healthcare-associated infections, HCAIs.
Right, hospital infections?
Yes, exactly. They affect about 7% of hospital patients in high-income countries and 15% in LMICs. That leads to substantial disability and premature mortality.
15% in LMICs.
Then we have venous thromboembolisms, or VTEs, blood clots.
Ah.
They're common and highly preventable, yet tragically, they're the leading cause of harm in LMICs and the biggest source of lost healthy life years globally.
The leading cause, wow.
Yeah. Common preventable issues in hospitals also include things like patient falls and pressure ulcers.
Bed sores.
Exactly.
Okay.
And we can't overlook patient identification errors, which can lead to severe events like wrong patient surgery
Oh, man.
and unsafe transfusion or injection practices. The latter, unsafe injections, were responsible for millions of hepatitis and HIV infections globally just between 2000 and 2010.
Millions.
It's truly a pervasive and multifaceted issue across almost every facet of medical care.
We've spent a lot of time on the human cost, the lives lost, the disabilities incurred. It's devastating. But what does all of this mean for healthcare systems themselves and, for national economies? Our deep dive into the numbers reveals that unsafe care isn't just tragic, it's also an enormous financial drain,
Huge.
consuming resources that could be far better utilized.
This is where the economic picture truly comes into sharp focus, and it's quite shocking. In high-income countries, a staggering 12.6% of total health expenditure.
12.6%.
Yeah, that's roughly $878 billion annually, is consumed just by managing the consequences of patient harm.
Wait, say that again. 878 billion.
Annually, just think about that for a moment.
Yeah.
It means nearly $1 out of every $8 spent on healthcare in these nations isn't going towards treating new illnesses, but rather fixing problems created within the system.
So only about 87% is for actual new problems.
It's exactly. The remaining 87.4% is what's left for spontaneous illness.
Yeah.
While comprehensive studies are still limited for LMICs, early data suggests similar proportions of their budgets are affected. For instance, in Thailand, it was estimated at 5.5% of their national health budget, or about $278 million annually.
That's an astonishing amount of money being absorbed just to correct errors. Can you give us some specific examples of how these direct costs manifest? Like, where does that money actually go?
Absolutely. Take healthcare-associated infections, HCAIs, for example. They don't just prolong patient stays, they can almost triple treatment costs.
Critical.
Yeah. Hospital-acquired VTEs alone, those preventable blood clots we mentioned, cost the U.S. an estimated $7 to $10 billion every single year.
7 to 10 billion just for VTEs.
Just for those. And surgical harm. It's directly linked to a twofold increase in length of stay and a 1.5-fold jump in direct hospital costs. And even in primary care, a realm we often perceive as less risky, adverse drug events, ADEs, and misdiagnoses frequently lead to emergency visits and hospital admissions that were entirely avoidable. This alone costs OECD countries an estimated $54 billion annually just for ADEs.
54 billion just for adverse drug events.
It's a consistent pattern of wasted resources across the board.
Those are the direct costs, the treatment costs, but our sources also highlight something even larger. The indirect costs. What are we talking about there, and how do they compare?
Right. The indirect costs are often far greater, frequently overlooked, and represent the true hidden burden.
Okay.
These encompass things like the loss of productivity, reduced labor participation, income loss for patients, and often their caregivers too. Our sources indicate these can exceed direct costs by orders of magnitude.
Orders of magnitude?
Yeah.
Really?
A study in Australia, for instance, found that the indirect costs of surgical site infections were 9 times higher than the direct costs, primarily driven by lost productivity.
9 times higher.
Similarly, for pressure ulcers, indirect costs significantly outstrip direct ones. This compels us to ask, what is the true comprehensive toll of an ailing healthcare system on a national economy? Especially when disadvantaged populations often bear a disproportionate share of these indirect costs, which just makes existing income inequalities even worse.
That's a powerful point. So if we step back and look at the global economic implications of all this, the numbers are, quite frankly, staggering.
They really are. The sources suggest that patient harm could potentially reduce global economic output by up to 0.7% each year.
0.7% of global GDP.
Potentially. But here's the truly mind-boggling thought experiment presented in the material.
Yeah.
If all unsafe care had been eliminated back in the year 2000,
Okay.
the gross world product could have been 15% higher 2 decades later.
15% higher.
Globally, we're talking a cumulative gain of around $120 trillion.
$120 trillion. That's almost unbelievable.
So it shows this isn't merely about healthcare efficiency. It's about unlocking massive global economic potential.
And if you look at it from a willingness to pay perspective, essentially, how much societies are collectively willing to pay to prevent illness and disability.
Right, the value people place on health.
The annual global societal cost of unsafe care is estimated at an absolutely staggering $1.17 trillion.
Over $1 trillion a year. These aren't just abstract figures. They represent real opportunities lost, real value destroyed.
Absolutely.
And what's truly encouraging in the research, despite these immense costs, is the powerful return on investment that patient safety interventions offer.
Ah, okay, so there's good news here.
Definitely.
Yep.
Many strategies are incredibly cost-effective, practically a no-brainer. For example, interventions specifically targeting healthcare-associated infections can deliver a saving-to-cost ratio of 7.1.
7 to 1.
Yeah. For every dollar you invest in preventing these infections, you save 7.
That's incredible ROI.
It really is. The WHO Surgical Safety Checklist is highlighted as a prime example, a highly effective and universally applicable tool. It reduces surgical harms, improves outcomes across all income levels.
Right, I've heard of that checklist.
And even technological interventions like implementing barcodes for medication administration or computerized provider order entry systems, CPOE, they're proven to be cost-effective in drastically reducing medication errors.
So the tech helps too.
It does. This fundamentally shifts the perspective. Improving safety isn't just an ethical imperative or a medical benefit, it's an economically astute decision. It pays for itself many times over.
So with such an immense problem, a human tragedy and this massive economic drain, how effective are we globally at actually tracking it? Our deep dive reveals a significant hurdle here, doesn't it?
It does. A critical challenge that emerges from the sources is the current lack of an internationally agreed upon standardized measurement strategy.
No standard way to measure it.
Yeah, exactly. We simply don't have a reliable, universal way to identify, analyze, and monitor the true burden of patient harm or, importantly, the impact of safety improvement programs. This means, particularly in LMICs where infrastructure like data collection and record keeping is often inadequate, the problem is likely significantly underestimated.
So the numbers we have, as bad as they are, might be conservative.
Very likely, yes. We're fighting a battle we can't fully see.
That hidden burden is a powerful phrase. It makes me wonder about the ripple effects beyond just the patients. What about the healthcare workers themselves? They're, on the front lines of this.
That's such a crucial dimension, and one that needs much more attention. Patient harm isn't just devastating for patients. It carries a major hidden burden on health workers. They're often tragically described as second victims.
Second victims.
Yeah. They experience significant detrimental impacts on their own physical and mental health. It can lead to burnout, retention problems, and sadly, it can even face increased risks for more unsafe care incidents themselves because of the stress and trauma.
A vicious cycle.
It can be. This points to a fundamental need to shift away from a punitive blame culture where we just point fingers to what's known as a just culture.
Okay, what's a just culture?
It's one that balances accountability, which is still important, with a systemic approach to preventing future adverse events. It focuses on learning from errors and supporting staff rather than just punishing them when things go wrong. Understand that usually the system plays a part.
That makes a lot of sense. So how do we move forward from this? What steps are our sources suggesting to truly tackle this from a systemic measurement perspective and maybe even from the patient side?
Well, the research strongly advocates for a shift from the current, often non-systematic voluntary reporting, which we know misses so much, to coordinated systematic measurement.
What would that look like?
It could involve things like national audits, targeted screening programs, maybe annual reviews of a sample of patient charts to create a truly reliable map of patient safety across the system.
Getting better data, basically.
Exactly. And crucially, it highlights the immense power of patient engagement and health literacy.
Ah, so bringing the patient into it.
Absolutely. When patients are actively involved, when they're empowered with information and understand their care plan, they become a vital part of the safety net. They can spot things, ask questions.
Yeah.
Our sources indicate that by effectively applying these strategies, systematic measurement and patient engagement harm could potentially be decreased by up to 15%.
15% reduction just from that.
Up to 15%. That's a massive benefit for everyone involved. Patients get safer care, and healthcare systems become more efficient and effective.
Today, we've taken a really deep dive into the profound, often invisible burden of harm in healthcare. We've seen the shocking global statistics, millions of preventable deaths, hundreds of billions, even trillions in financial costs. We've explored the disproportionate impact on vulnerable populations and looked at how this issue is a significant drag on global economic potential. It's abundantly clear this isn't just a medical problem, but a deeply societal one. But, as we've also discovered, while the problem is immense, so too is the opportunity for improvement. With strategic, smart investments yielding significant returns, both human and financial.
And that leads us to a powerful question, perhaps, for you to consider as you reflect on this deep dive.
Okay.
Given the staggering human life and economic resources currently consumed by preventable harm, what would it truly mean for our global society, for our economies, for our communities, for individual well-being, if we collectively committed to genuinely eradicating preventable harm in healthcare within our lifetime? What could we actually achieve with all those freed up resources and lives?
A truly transformative thought to leave you with, isn't it? Thank you so much for joining us on this deep dive. We hope you feel a little more well-informed and perhaps a little more inspired to ask important questions about the safety of care in your own communities. Until next time, keep learning, keep questioning, and keep making those connections.